Hey everybody, this is Dr. Susan Bliss in the Department of OBGYN at Atrium Health. Today we're going to talk about gynecologic and obstetric ultrasound. We're going to start our objectives today by discussing the indications for GYN ultrasound. We're going to look at some normal and abnormal uterine pictures. We're going to review some adnexal images, and then we're going to review first trimester ultrasounds. For the most part, we use transvaginal ultrasound when doing gynecologic imaging. This offers several advantages. We have proximity of the probe to the target organs, and because of this proximity, we are able to use higher frequency probes, which leads to improved resolution. The nearest zone to the probe gives us the most precise image. With the higher frequency probe, we have a slightly decreased depth of field, so that we are less able to visualize any pathology or organs that are greater than 9 or 10 centimeters away from the probe. Some of the indications for ultrasound include abnormal bleeding, an enlarged uterus, pelvic pain, or an abnormal bimanual exam. So let's get started with transvaginal ultrasound. The trickiest part is keeping oriented. It's kind of like the image here where as you're up in the air, you don't know which way is up, which way is down, and you hope that you're going to land on your feet. So, keeping oriented in transvaginal ultrasound, in the sagittal plane, on the image, you have to remember that the anterior or ventral portion of the patient is on the left of the screen, and the posterior or dorsal portion of the patient is on the right of the screen. When we look in the coronal plane, we do a 90-degree counterclockwise rotation of the probe, and the patient's right is on the left of the screen, and the patient's left is on the right of the screen. So when we do transvaginal ultrasound, we talk about the sagittal plane and the coronal plane. It's only when we're doing transabdominal ultrasound that we talk about the transverse plane. So I'm going to give you a couple of images to look at orientation. So this first slide shows the probe in the patient's vagina. You can see the bladder anterior to the uterus and the rectum posterior to the uterus. In this image, her uterus is anteverted, pointing up to her anterior abdominal wall. The thing that makes it difficult is the way we look at it on the screen. So when we look at ultrasound transvaginal images on the screen, the inferior portion of the patient is on the top of the screen, the superior portion of the patient is on the bottom of the screen, anterior is to the left, and posterior is to the right. We're going to put this all together on this next slide, and you can see the probe is still in the patient's vagina, anterior is to the left, posterior to the right, inferior is up, and superior is down. Again, here it is, and all superimposed. So the probe is in the vagina, we see the uterus, we see the bladder, we see the rectum. So hopefully this slide will keep you oriented as you do your transvaginal ultrasound. Next, we're going to look at some uterine positions. When we're examining the uterus, the first thing we want to look at is position. Is it anteverted or is it retroverted? We want to look at the overall size, and then we want to examine the uterus from cervix up to the fundus, and then measure the endometrial thickness if indicated. Here are several examples of different uterine positions. In the top left image, this uterus is anteverted, as evidenced by the top of the uterine fundus pointing to the left of the screen. In the top right image, this uterus is retroverted, as evidenced by the fundus pointing towards the right of the screen, which is posterior. In the bottom image, the uterine fundus points straight down to the floor, which is a mid-plane uterus, so it's neither anteverted nor retroverted. As we examine the uterus, we look at it all the way up to the fundus. And so what you can see here is the fundus of the uterus, and just to the left of the screen, you see a darker area, which is the bladder, and we know that the bladder is anterior to the uterine fundus. Next, we're going to go into the coronal plane, and to get to the coronal plane, again, we take the transducer and we do a 90-degree counterclockwise turn. And so we measured the uterus in the coronal plane from left to right, right to left, and we measure the transverse diameter of the uterus in the coronal plane. Next thing we want to do is look at the cervix. And in this slide, we see several small black circles down in the cervix, and those are called Nabothian cysts. Nabothian cysts are remnants of endocervical glands, and they're completely normal. Next is an example of a bicornuate uterus, and this is evidenced by the two arrows which point to the two endometrial cavities that we can see. Interestingly, this patient not only had a bicornuate uterus, but she also has a uterine fibroid off of the left horn of her uterus. The pink arrows, again, point to the endometrial cavities of the two horns, and the orange arrow points to the fibroid, which is coming off of the left horn of her uterus. So this slide is a nice transition, to talk about fibroids. Fibroids tend to be spherical. They can be pedunculated, which means on a stalk attached to the uterus. They can undergo cystic degeneration, which would make them hypoechoic. They can also undergo calcification, which causes shadowing because the sound waves do not traverse the calcium as well as they do the myometrial tissue. There are three types of fibroids. There are intramural, subserosal, and submucosal, and we're going to look at these next. The next slide shows an intramural fibroid and shadowing. So the pink arrow is pointing to the fibroid, and the orange area is the black shadowing that is caused by the fibroid being so dense that it absorbs the majority of the sound waves, so there are no sound waves that are able to penetrate beyond the fibroid. Next, we're going to look at a submucosal fibroid. So submucosal means underneath the endometrium. So this is a submucosal fibroid measuring about 2.8 centimeters, and normally it's not this distinct, but we have the advantage of having instilled some saline inside her uterus, and that's how it's easy to see this submucosal fibroid. Submucosal fibroids tend to impact the endometrial lining, so they tend to cause bleeding problems for the patient during her period, and even intermenstrual bleeding. Lastly, subserosal fibroids are the ones that are found on the outer surface of the uterus. And here we have a coronal view of this uterus with a subserosal fibroid. And the subserosal fibroid is that which we see within the circle. Next, we have a fibroid that's undergone a little bit of calcification. And again, calcium does not absorb sound waves, so you see shadowing beyond the calcified fibroid. And the pink oval is circling the calcified area of this fibroid. The next thing that we're going to talk about is the endometrium. And the endometrium is a very dynamic organ. It has cyclic changes under the influence of the ovarian hormones. The endometrium is comprised of two main layers, the basalis layer, which is unchanged throughout the menstrual cycle, and the functionalis layer, which is what changes based on the ovarian hormones. And the glands within the functionalis layer determine the echogenic pattern. During the proliferative phase, which is pre-ovulatory, it tends to be hypoechoic due to narrow glands and a low gland to stroma ratio. However, in the secretory phase, it becomes hyperechoic or brighter, whiter due to the increased glandular volume. During the proliferative phase, again pre-ovulatory, it tends to be trilaminar. It has three layers. The first layer is the basalis layer, which defines the interface between the endometrium and the myometrium. The next layer is the functionalis layer, where the glands are hypoechoic, so it tends to be a darker black. And then the third layer we see is the bright specular reflection, which is where the two surfaces of the functionalis layer come together. During the secretory phase, we lose the trilaminar view. It becomes much thicker, and the glands become much more tortuous and occupy more volume. So we see up to 2 centimeter thickness, which is totally normal in the secretory phase. And again, we lose that trilaminar view. The next slide is going to show you the menstrual cycle. And this is a slide that I think every student of medicine has studied and memorized and forgotten, but it's a really, really important one to help understand what's happening in the pituitary hormones, the ovarian hormones, the ovarian follicles, and corpus luteum, and what those hormones are doing to the endometrium. So here we have the menstrual cycle. In the pre-ovulatory phase, the FSH is the more predominant hormone coming out of the anterior pituitary. The FSH acts on the ovary to grow a follicle, because FSH is follicle stimulating hormone. And as that follicle grows, it produces estradiol. The estradiol acts on the uterus to cause the endometrium to become proliferative. After ovulation, the follicle becomes a corpus luteum, and this is called the luteal phase. The corpus luteum secretes progesterone, and the progesterone acts on the endometrium to make it more secretory. If pregnancy does not occur, then the progesterone levels drop and menses ensue. So when we're measuring the endometrial stripe, we want to measure it at its thickest site, and we want to measure from basalis layer to basalis layer, so both walls of the endometrium. And if there's any intracavitary fluid, we want to subtract that out. We expect the endometrial stripe to be less than 5 millimeters in postmenopausal women, since they are not under the influence of estrogen. We expect it to be less than 5 millimeters in patients on combined oral contraceptive pills, since they are progesterone predominant, or on a patient who's on Depo-Provera, or in a patient who's been on a GnRH agonist for more than 3 weeks. So now we're going to look at an endometrial stripe as we go through a menstrual cycle. So in this first slide, we can see a thin endometrium because this patient has just finished her menses. So she has a very thin endometrial stripe. And you can see the hormones that are influencing it at this point. She's got low estrogen and low FSH at this point. As we move to the mid-proliferative phase, we can see the trilaminar view. And so what I'm going to do is point out the 3 layers here. 1, 2, 3. That's the trilaminar view. The middle stripe is the bright specular reflection where the 2 surfaces come together. So again, I want you to see the trilaminar view. And at this point, the endometrium is mostly under the influence of estradiol. And then as we shift a little bit later proliferative, you can see the endometrium has gotten a little bit thicker, and it still has a trilaminar view, but it's just starting to lose it a little bit. And then once ovulation occurs, it turns into the secretory phase, and you can see this is much thicker. It measures about 2 centimeters, and it is now under the influence of progesterone. Once the progesterone is withdrawn, then she will shed her menses. So a 2 centimeter stripe is completely normal in a cycling woman. Next, we're going to talk briefly about saline infusion sonography. This is a patient who's 27 years old. She's never been pregnant. She's been on OCPs for 6 years, and now she presents with intermenstrual bleeding. So that's why she presented for her GYN ultrasound. And what you can see is her ultrasound. On the ultrasound, you can see the endocervical stripe going up to the endometrium, but then it just stops before it gets to the fundus. And what you can see is there's a solid mass there. So what we did for her was we instilled some saline inside of her uterus, and this separated the walls. And what you can see is she had a submucosal fibroid that was the cause of her bleeding. She did not have a thickened endometrial stripe because she was on combined oral contraceptive pills. So we managed this with a hysteroscopy, and in the bottom right corner, you can see the fibroid, and this was easily resected, and she had no further problems with intermenstrual bleeding and was very happy. Next, we're going to talk about first trimester evaluation. So how we use ultrasound is to establish the location of the pregnancy. Is it in the uterus? Is it not in the uterus? Then we want to establish the nature of the pregnancy. Is it normal? Is it not normal? Or does she have any retained products of conception in her uterine cavity? So back in the caveman days, they said, hunter-gatherer, we don't really care as long as it's healthy. Well, with the advent of ultrasound, we have lots of ability to assess very early a pregnancy. So because we have this ability, we need to use our ultrasound wisely. Ultrasound is essential to assess the early pregnancy viability in women with bleeding. The problem is that it's so simple that sometimes we miss critical data. So it's important that we measure an accurate crown rump length, the yolk sac and its size, and whether there's fetal heart rate or fetal cardiac activity. And sometimes it's easy because we're so focused on the pregnancy that we might overlook any pathologic states that might compromise the pregnancy, such as uterine anomalies or fibroids or gestational trophoblastic disease. And also we must look at the ovaries to make sure there are no abnormalities there. This next image is an early intrauterine pregnancy. And this is an anteverted uterus, and the dark sac in the middle is the gestational sac, and that's outlined with the pink line here. And then within the gestational sac, we can actually see a yolk sac, which is shown by the pink arrow. That's a yolk sac. So when we're measuring the gestational sac, we want to measure the mean sac diameter in centimeters. So we want to measure it in the sagittal plane. We take 2 measurements, and then we go to the coronal plane, which again is a 90-degree counterclockwise turn, and we just measure 1 measurement in the coronal plane. And we just take those 3 diameters, average them, and that is the mean sac diameter. This will be important later as we talk about what we expect to see. The next slide shows us measuring the embryonic length, also known as the fetal pole, and also known as the crown rump length, CRL. We measure from the top of the crown, where the arrow is, to the bottom of the rump, which is where the other arrow is. And sort of posterior to the fetus, you can see a little black circle, and that's the yolk sac. That is extra amniotic, and that usually disappears by about 10 weeks, or a little after 10 to 12 weeks. And just a clinical pearl, whatever the crown rump length is in centimeters, if you add the factor 6.5, that will give you the estimated gestational age in menstrual weeks. I like that pearl because it's quick and easy. However, most of the machines today have this automatically calculated in it, so you don't necessarily have to memorize that. Another handy rule of 2s that I find extremely helpful, but is not a hard and fast rule, is, again, the rule of 2s. If the quantitative HCG is greater than 2,000, then on ultrasound you should see an intrauterine gestational sac. If the mean sac size is greater than 2 centimeters, then you should see a fetal pole or a crown rump length. If the fetal pole is greater than 1/2, so 1/2 a centimeter, then you should see cardiac activity. And it's important to remember these are just approximate guidelines to be quick and easy, but the clinical setting is critical. Her labs and the patient's desire for this pregnancy are important factors in determining what to do with the next steps. Next, I'm just going to take you through some first trimester crown rump lengths. So this ultrasound shows a crown rump length at 5 weeks. And what you can see, if you look really carefully, is the crown rump length is 1.5 millimeters. So that's very, very tiny, but you can see the crown rump length adjacent to the yolk sac. The next image shows the yolk sac again. The next image shows at 6 weeks, the crown rump length is 3.4 millimeters, but at 6 weeks, in this particular one, we actually can see some fetal cardiac activity. By 7 weeks, we see both the crown rump length and the yolk sac, and we certainly should be able to see fetal cardiac activity there. At 8 weeks, you can see the crown rump length, and you can actually sort of see the amnion surrounding the fetus, the embryo actually at this gestational age. And then at 11 weeks, we can clearly see the crown rump length, and it's already up to 4.4 centimeters. And now at this point, there is no longer seen a yolk sac. The placenta will be taking over. So our first case is a 22-year-old G1 who has vaginal spotting. And this is what we see on her ultrasound. What you can see is her mean sac diameter is 2.4, her measurements are 2.4 by 2.1, then in the coronal plane by 3.5. So her mean sac diameter is greater than 2 centimeters, and we don't see any yolk sac and we don't see any fetal pole. So this is most likely an anembryonic pregnancy. And the management really depends on the patient's desire for this pregnancy. There's no rush to intervene. And so if the patient says this is a highly desired pregnancy, we can just wait and give her expectant management and bring her back for repeat beta HCG and repeat ultrasound. Our next patient is a 28-year-old G3P0020 who presented with vaginal spotting. And what we can see on this slide is we see her uterus, which does not show a gestational sac within it. We see anterior to her uterus some blood and clot, and then anterior to that, we can see just a slight corner of her bladder. Next, when we go to her coronal view, again, 90-degree counterclockwise turn, we see an empty uterus, and out in the patient's right, we see a gestational sac, which is an ectopic pregnancy within the tube. So we see a gestational sac and a yolk sac. So this is an ectopic pregnancy, and the management for her would be surgical, given the fact that the size of the ectopic is greater than 3.5 centimeters. So here we've seen a couple of abnormal early first trimester ultrasounds. One, expectant management is appropriate. The other, expectant management is not appropriate. Next, just to make sure you're awake, we're going to look at some top list answers. So this is just a little transition as we look at the adnexa. The adnexa are adjacent to the uterus. They include the fallopian tube, the ovary, and again, they are usually lateral to the uterus. Sometimes they can be posterior to the uterus, and sometimes they could be anterior. Sometimes if it's difficult to find the adnexa, we look for the underlying internal iliac vessels, which are in the inferolateral portion of the image. So when we're looking at the adnexa, this is what we commonly see. And the measurements here, the distance here is 3.4 centimeters. We can see some hypoechoic areas within it. And this is actually a normal ovary with one dominant follicle. So normal ovarian measurements are in the 3 to 6 centimeter range. And this is a completely normal ovary. This next ovary also is in the normal range. It's about 2.5 centimeters. But what you'll notice is there are lots of similarly sized follicles all around the periphery of this ovary. And this is what we call the string of pearls, which is suggestive of polycystic ovarian syndrome. Here is another example of similarly sized follicles lining the periphery of the ovary. And this again is an example suggestive of polycystic ovarian syndrome. But what you'll notice in both of these two, the ovary is normal in size. More frequently with polycystic ovarian syndrome, the ovary is a little bit more enlarged. Next, we're going to look at talk about adnexal masses. And some of the key things with adnexal masses are they cystic or solid? Are they simple or complex? What is the site of origin of the adnexal mass? And what is the size of the adnexal mass? So the most important thing when we have an adnexal mass or an adnexal cyst is looking at the morphology, because the key thing is it benign or is it malignant? And so ultrasound can really help us to determine whether it's benign or malignant. So the probability of malignancy there are certain features that would suggest a lower suspicion or a higher suspicion. So if the cyst wall is entirely smooth, that's a low probability of malignancy. If it's got papillations or is bumpy, that's a high suspicion of malignancy. If the wall thickness or the septations are less than 3 millimeters, that's a low probability of malignancy. And if it's greater than 3 millimeters, that's higher suspicion for malignancy. If there are no septations and it's entirely simple, that's reassuring. If there are more septations, that's more suspicious. And then if there are solid components, that would be suspicious for malignancy. And if it's entirely cystic, that's a low probability. So the patient's age is also critically important. And if we have a postmenopausal woman with an adnexal mass, that raises our level of suspicion. So this first image is an adnexal cyst. You can see the measurement is 9.72 centimeters. As you look along the cyst wall, it's entirely smooth, it's entirely simple, there are no septations. This is a simple cyst, and studies have shown that 2/3 of these will regress spontaneously. So there's no need to intervene immediately, and we can bring her back for a follow-up ultrasound in approximately 12 weeks or 3 months. This next cyst is much smaller. However, it has 2 septations through it. So this is a septated cyst. Again, based on its size and based on the thinness of the septations, the septation here measures 2.5 millimeters. This is very reassuring. And so this is a septated cyst, and we would recommend a follow-up ultrasound in 3 months. Our next patient is a 33-year-old. She's a G4P2A2 with a 1-week history of left lower quadrant pain. She has a history of a right salpingo oophorectomy for cysts approximately 10 years ago. So this is her one and only remaining ovary. As we do her ultrasound, what we see is this cyst, which could appear to have multiple septations within it, but what this actually represents is hemorrhage within the cyst. So this is actually a hemorrhagic corpus luteum. And so for her, rather than jump to surgical management and risk castrating her, we allowed expectant management, and we did a follow-up ultrasound in 6 to 12 weeks, at which point this had completely resolved. So this was a hemorrhagic corpus luteum, which is not uncommon. And again, given her age, we felt very comfortable using expectant management. Our next patient is a 37-year-old G2P0 who's currently pregnant, and she has a history of 3 laparoscopies and laser ablation of endometriosis or endometriotic implants. She's currently pregnant at 18 weeks, and she has a complex adnexal mass, which we see in this ultrasound. And what we can see is there's a hypoechoic area in the bottom left of the picture. She's got some medium echogenicity and then some higher echogenicity sort of on the right of this complex mass. We elected to repeat her ultrasound, and what we saw was very, very similar. She had the hypoechoic, the medium echogenic area, and the bright echogenic area. And if we put the two side by side, again, 2 months apart, despite the fact that it's a different machine scanning, you can see that they have very, very, very similar appearance. And given her history of endometriosis, we determined that this was an endometrioma, and we did nothing except expectant management during her pregnancy. And she had a successful pregnancy, and this did turn out to be an endometrioma. Another patient, 25-year-old G0, who presented with pelvic pain, underwent GYN ultrasound, and she too had a hypoechoic area and sort of a hyper or medium echogenic area. In this case, shows an endometrioma, again with layering. And we often describe the layering, the material within an endometrioma, as a chocolate cyst. So we took this patient for laparoscopy, and what you can see here, the top left picture is her uterus at laparoscopy and her 2 ovaries, which are enlarged. We also looked at her peritoneum, and we can, in the top right picture, you can see several dark spots, which are small endometriotic implants. In the bottom right picture is her appendix, and we always want to check the appendix to see if there is any endometriosis on the appendix. And these were bilateral endometriomas, and we attempted to shell them out. And here's the chocolate material, and one of these endometriomas ruptured, and so this is the chocolate cyst that we see with endometriomas. And we were able to shell out both endometriomas and leave her functional ovarian tissue. Our next patient is a 35-year-old G3P3 whose status post-BTL, and on bimanual exam, her clinician felt an enlarged ovary. The patient denied any pain, had no complaints, so she was referred to us for ultrasound. On sagittal view, we saw this in her ovary, and what you can see is sort of a brighter area in the top left portion of the picture, a hypoechoic area in the middle of the ovary, and then a medium echogenic area. And just remember how the endometrioma layered. This is not layering. This has the bright area up toward the left. When we take our 90-degree counterclockwise turn and look at this in the coronal plane, we can still see some bright areas, and we can see the black circle, which is a follicle. And this turned out to be a dermoid cyst, also called a cystic teratoma, and these are derived from all 3 dermal layers. Next, we have a 37-year-old G4P4 who presented with pelvic pain. So as the ultrasound tech did this, as you can see on here, she labeled it endometrioma. So remember that we have to maintain our differential diagnosis, and this did not turn out to be an endometrioma. This is actually another dermoid cyst. The area that is marked is actually hair, which is coming from the ectodermal layer of the dermoid cyst. And when we look at her other ovary, we see another collection of hair, which again is from the ectodermal layer of the dermoid cyst. So these will not regress on their own, and we took this patient to surgery. And what we can see here is the laparoscopic pictures. In the top left corner is the pink is the uterus, the white is the ovary, and you can see that her right ovary is more enlarged than her left ovary. And again, we try and shell out these dermoid cysts. And this patient had bilateral dermoids. And so as we incise and shell them out, occasionally they do rupture. And in the top left picture, you can see it shelling out, but in the bottom right picture, it has ruptured, and so you can see sebaceous material and hair both arising from the dermoid cyst. We are usually able to leave her some functioning ovarian tissue, so this will not decrease her fertility. This next image is a 45-year-old patient with right lower quadrant pain. And what you can see is two cystic structures adjacent to each other, which the sonographer has labeled right ovary. And it's really important when you have two cystic structures that you rotate your probe to confirm whether or not these two cystic structures communicate with each other. So as we turn the probe, what we can see is that they actually do communicate with each other. And this patient actually has a hydrosalpinx, which is fluid inside the tube. And so on cross-section, it might look like a simple cyst, but in reality, they communicate with each other, and this is actually a hydrosalpinx. So this would be surgically removed given the patient's pain. Our next patient is a 62-year-old G0 with a family history of ovarian cancer. So we don't use ultrasound as a routine screening for ovarian cancer. However, in a patient with a family history, she may qualify for screening via ultrasound. So on her screening exam, this is her left ovary. It measures 3 by 1.8. She's 62 years old. She's postmenopausal. This is a totally normal ovary in a postmenopausal patient. So she was very, very reassured. She came back 1 year later without any symptoms, and that same ovary looked like this. And what you can see is some bright areas, some hypoechoic areas, and some medium echogenic areas. So in a patient who's postmenopausal, this is extremely worrisome. If this patient were 22 instead of 62, my differential would absolutely include a dermoid cyst. But in a 62-year-old with a family history, we have to assume, we have to pursue this very aggressively. As we took another image of her ovary on that same day, what we can see are some papillations, which is where the cyst wall is not entirely smooth. It has some projections. So this was presumed to be ovarian cancer. She went for surgery and was successfully managed and caught at an early stage, which is very lucky for her. So she did very well postoperatively and is here to tell us her story. So, in summary, we've seen how ultrasound improves our clinical acumen in both OB and GYN. We have seen how orientation is very important. We've looked at some first trimester evaluation, the rule of twos. So you can go back and review that slide. It's just a handy guideline. And then another handy guideline is the crown rump length in centimeters plus 6.5 is the estimated gestational age. If you have any further questions, please feel free to ask them when we're in person.